Chest pain is a symptom that is understandably very worrying because it can be associated with significant underlying heart disease. There are, of course, many other causes of chest pain, and in a lot of cases, patients come to see me either in the hospital or in the clinic can be reassured that actually everything's all right with the heart, and this allows them to move forwards with reassurance about the condition of their heart. When we're talking about pain from the heart causing chest pain, we're often talking about cholesterol buildup causing narrowings and blockages in the arteries around the heart, so that when the heart's working a bit harder, so for example when you're walking up the stairs or walking up a hill, the amount of blood flowing down the arteries is not enough, and you often get a heavy or a tight pain in the chest that might go up the neck to the jaw, might go down the arm, might go down to the stomach, although people do feel their symptoms a bit differently. There are thankfully many other causes of chest pain, and often it's not the heart. It may be due to the bones and the muscles and the nerves in the chest. It might be due to acid reflux causing spasm of the gullet right behind the breastbone in the chest. It might be related to a sensation of breathlessness, or even anxiety, and stress can give you a tight or heavy feeling in the chest. The important thing is to take the history well, examine the patient well, get the ECG, and make sure you're making the right diagnosis. And therefore, if there is a heart problem, you can identify it early and get it sorted out before any serious complications occur. Or if it's not a heart problem, you can provide the reassurance and then allow that patient to move forward with confidence that their heart is okay. I should mention that if you do get a severe chest pain at rest that's not going away, you should, of course, go up to A&E because that can be associated with a heart attack or inflammation in the heart. But certainly any other type of chest pain, it's important to see the right specialist early, make the right diagnosis, and then move forwards with confidence. When I assess a patient with chest pain, the single most important thing is to take a really good history. So you need to understand what the pain is like, what the pattern of the pain is, and perhaps most importantly, what the impact of that pain on the patient is. Because if you don't understand all the other factors going into it, you're never going to be able to make a holistic diagnosis and a holistic management plan going forward that's satisfactory for everybody involved. Once I've taken the history, there's often several clues there as to what might be causing the pain, depending on the pattern of it. You then do a thorough examination and you do an ECG, which gives you lots of clues as to what might be going on and what might be causing the pain. The next thing to think about is what investigations you want to do. So the question I ask myself is, could this be a heart type pain? If so, what heart investigation would be most appropriate? Or is this a not heart pains coming from somewhere else in the chest? In which case, again, you speak to the patient, see what their concerns are, see what the right investigation is, and you move forwards from there. But the single most important thing is listening to the patient, getting the history, understanding the symptoms they're getting, and then using that evidence to make the right management plan, the right investigation plan, so you end up with the right solution at the end of it. The test that we use to investigate chest pain very much depends on what the likely diagnosis is. And as I said before, the single most important thing is understanding the history, the examination findings, and the ECG, because already you should have a fairly clear idea in your mind what the likely causes of these symptoms are. In some cases, from the history, the examination, the ECG, I can make a diagnosis straight away, and the patient can be reassured and can move forward without any further investigations. If investigations are needed, in the vast majority of cases, these are non-invasive in the first instance, so they're not painful and they're not dangerous to go through. If we're looking at the heart, to look at the arteries, one of the most common investigations that we do is a CT scan of the arteries around the heart, which is where they put a cannula into your arm and you go into one of those donut-shaped scanners. It takes a matter of a few minutes, and we get very nice 3D reconstruction pictures of the arteries around the heart, and we can see right away if there's any narrowing or blockage there that might need further investigation or treatment. If we're trying to avoid radiation, a very good test is a stress echocardiogram. So this is a very good MOT test for the heart because we get you to exercise on a treadmill, or if you can't do that, we can give you an injection of medicine to speed the heart up a bit. And then we do echo scans, which is an ultrasound, looking at your heart at various points during your exercise when your heart's going faster. And we can understand if there's any limitation to blood flow to the heart. We can understand if there's a problem with the valves or with the function of the heart. So it gives us a huge amount of information about the heart in a very safe and easy way that doesn't involve any radiation. In a few cases where the risk of coronary disease is very high, we do proceed straight to invasive angiography, which is a local anaesthetic procedure where we inject a bit of anaesthetic into the wrist, we put a little tube into the artery in the wrist, and we squirt some dye down the arteries into the heart. And we can have a look at the arteries and see if there are any narrowings or blockages there. And in many cases, if there is a narrowing or blockage that needs fixing, we can fix it using a balloon and a stent all through the tube in the wrist, all at the same time. There are various other tests that might be necessary, such as an exercise treadmill test, where we get you walking on a treadmill while doing an ECG. We might do a plain echocardiogram, we might do an MRI scan of your heart, and we might do a nuclear perfusion scan of the heart or a 24-hour ECG. But these are the main tests, and certainly in the vast majority of cases, initial investigation is painless and non-invasive and very low risk, and gives us lots of information about the heart that we can take things forward with. The management of recurrent or ongoing chest pain very much depends on what the underlying diagnosis is. So this is why it's very important to get the right diagnosis up front so that you can really target your treatment to the right thing and get your patient better, which is what we're aiming to achieve at the end of the day. If it is non-cardiac chest pain, you look for the underlying cause, whatever that might be. You can offer targeted treatment to that, along with reassurance that it's not a heart problem and they don't need to worry about their heart, and hopefully can move forward with confidence and with the right treatment, whatever the cause of the pain is. If it does turn out to be angina, which is pain due to narrowings or blockages in the arteries around the heart, treatment will very much depend on where those blockages are in the arteries and how severe they are. In a lot of cases, it can be managed just with medications to get rid of the angina. We know this is effective in reducing risk and getting rid of symptoms going forwards. In some cases, if there are very severe blockages in the arteries, we talk about using a balloon and a stent to open up those arteries. So this is where we put a little tube into the wrist with local anaesthetic, squirt some dye down the arteries, see where the narrowings are, and use little wires and balloons and stents to open up the arteries from the inside and get rid of the narrowing or blockage that might be there. I don't do that actual procedure myself, but I do refer on to colleagues that I work very closely with to do that. If people have very severe or very diffuse narrowings and blockages in the arteries around the heart, we do bypass surgery in some cases. This really is a very small minority of cases these days, but can offer the best long-term cure for people in certain conditions. So getting the right treatment all depends on the whole process, starting with listening to your patient, getting the history, getting the examination findings right, doing the right investigations, and then coming out with the right treatment plan at the end so that we can be confident of a good future going forwards.